services like disease management programs and nurse practitioners to provide personalized care that only makes sense for someone who has high expected health care costs. For somebody who's perfectly healthy, you can give them a nurse and give them a lot of personalized attention. It's not going to lower their health care costs very much. And so these are plans that are specializing and say that healthy people need not apply. So this can be done. It's just a matter of setting up the policies in a way that directly takes on the problem. So those are at least two changes from what happened 15 years ago that I think could make a big difference today. Yeah.
Bill Clinton was here in December stumping for Hillary, and he mentioned in one of his speeches that by applying an electronic medical record, that would cover the cost of Hillary's plan and make coverage so much closer to universal. And I'm interested in kind of the applicability of that. Was that just rhetoric, or is that?
Well, no, that's what I said earlier. So you're going to hear that from every single one of the candidates. They want to get to universal care. They don't, universal health care coverage. They don't have the money to pay for it in the current system. So they have to start talking about things like quality improvement and preventing errors and disease prevention and electronic health records. I think my main comment on that would be, again, you still get what you pay for. There have been a lot of proposals to just add in to our current Medicare payment systems or Medicaid payment systems additional payments for electronic records. And I worry that unless we get the fundamental payment system right, that just doing everything electronically isn't going to necessarily save us money. You heard a few minutes ago about how a lot of doctors now have strong financial pressures to buy a CT scanner of their own. Well, if we did this, they'd have strong financial pressures to buy an electronic health record system of their own. Is that by itself going to lead to better coordination of care? Well, maybe, but probably not nearly as much as if we were doing something like these medical home payments that I talked about earlier, where not only can you have financial support for the electronic records, but you actually get paid better when you take steps to keep your patients well and to keep their overall costs down. I think just adding in payments for electronic records to our current payment system, which doesn't provide very strong support for steps to keep people well and coordinate their care well, by itself probably isn't going to save a lot of money.
Hi. Thank you for coming. You can pretty much answer this question if I'm misinformed, but I've heard in the past that there's a lot of fraud going on between the financial transactions and insurers and doctors, and that I've heard up to 30%. Now, I know a way to tackle that would be to have this regulation and oversight of doctors, and I know doctors wouldn't be very pleased about that. How would you have an oversight? We've talked about databases, and this question is very much related to the CT scans. How could you have an oversight where that would regulate that without, encroaching on the doctor's boundaries, if that makes sense?
Well, you could just go to, the sort of standard rules and enforcement regimes. If you just make the penalty big enough, if we just shoot the doctor when they're found guilty of doing this, they'll all probably stop doing it. But we probably won't go to that extreme either. I think the actual numbers of fraud in all